Thanks for the lovely introduction. Thanks for the organizers for having me here. So I'm from Canberra. That's not New South Wales, just to let you know. It's a distinct area in Australia. But anyway, let's focus this talk on the PTSD and the psychological outcome measures as the topic given to me. So I'm not going to talk much about other aspects of outcomes. I'm going to try and focus my talk on this. And why is that important? I mean, why am I wasting my time doing a PhD on this topic? Surely there must be a reason why we're doing this. I'll take you back to a statement or a narrative written by actually an ICU nurse on an ICUdelirium.org website, which states, who's a 50-year-old person, septic shock 4 years ago, says, I can't think clearly. My memory has suffered. And before sepsis, I was active. I was hiking, I was biking, I was rock climbing, and now I'm sedentary. I've seen doctor after doctor. They look at me and tell me I'm nuts. Or almost tell me I'm nuts. This has affected every aspect of my life. He's had to leave his job as an ICU nurse because it was wearing him out, or her out. I can't handle it. And this goes on to say, I just can't handle it. I would rather die. And this is actual words of an ICU survivor who is one of our community, who's one of the nurses who's gone through all that. So clearly there is a problem out there. You know, yes, we have been looking at mortality, and over the years mortality has been improving. This is ANZIC's APD data. I mean, we lead the world in how to do intensive care. Our mortality is one of the lowest out there. We do it well. But clearly, if you just look at mortality, well, there is a problem because something else is going on there. And there are a number of reports that come out in the media about all these problems with patients who are still picking up the pieces of the puzzle long after discharge from hospitals. So clearly there must be a problem. So, sure, this must be fake news. But I beg to differ. Unfortunately, it's not. Well, the Society of Critical Care Medicine really thinks this is not. So they had 2 stakeholder conferences established with a number of world leaders about trying to find out what are the long-term outcomes of these people who are discharged from intensive care. And they've come up with a number of things, but the most important thing, they came up with the term post-intensive care syndrome. So it's any kind of new onset cognitive, mental, or physical disability that happens with patients long after their discharge from that acute hospitalization. And there's a number of research now on this area, but let's focus on that key psychiatric and neurocognitive kind of outcomes. So again, number of data, number of studies out there, and it's not just because it's cool to publish on this topic, as nobody else is doing it, because there is a problem there. If you look at any of these studies, let's look at one-year outcome. This is a non-ARDS group, so most of the study and the literature is from the ARDS survivors, but let's look at the non-ARDS survivors. Post-traumatic stress, anxiety, depression, these patients 1 year after ICU, single center, around 200 patients, followed up for around 1 year. Pretty high post-traumatic stress disorders and anxieties. So you're looking at around 25% post-traumatic stress, around 30% anxiety, 30% depression in these patients. If you look at the data from this study, so IESR, or the impact of event scale, was used to measure PTSD. The cutoff for significant PTSD on this screening tool is 35, so let's look at that. So 27% of the patients having PTSD at 1 year. If you look at the HADS, which Carol's already mentioned, the anxiety scale of that, 18% with anxiety and 12% with depression. We're talking about, quite high levels of anxiety and depression, not just anxiety, normal anxiety or depression, which you could get at a lower level. So a significant issue. But if you follow this paper up, it's important why we need to measure this and when should we measure it. So if you look at around the 6-month mark or 3-month mark at follow-up, these patients look like they're coming down to baseline. But if you continue to follow them up, a lot of them have persistent symptoms at 12 months. And some actually have delayed symptoms. So the symptoms start to rise for some reason, whether that is due to physical disability, as Dale Needham says, who's written a lot about this, well, the head bone is always connected to the body bone, so there must be a problem. It might be physical disability which is causing the problem. We don't know. We don't know the answer to that. Well, let's look at the ARDS group long-term follow-up study, where a lot has been published on. And in this study, again, around 200 patients followed up for this 2-year longitudinal study. there was a lot of co-occurrence of anxiety, depression, and PTSD in these patients' populations. So around 50% or over of them had some extent of a psychiatric problem at a long-term follow-up. But more than 50% had supra-threshold symptoms. So there is clearly a significant issue that we need to measure. Let's look at a 5-year longitudinal outcome, because you would thought that some of these symptoms would start to come down, surely. But no, more than 50% of them have some kind of a domain of a neuropsychiatric problem long after discharge from their acute critical illness. And if you look at prolonged anxiety symptoms at 5 years, 38% of them, small numbers though. Prolonged PTSD symptoms, 23%. Prolonged depression symptoms, 32%. And there's a lot of co-occurrence of all these symptoms. There's again a study from Dale Needham's group. So let's try and focus now and take each one of these apart. So let's PTSD. So what about PTSD? Number of studies, again. Incidence varies. Depends on where you're doing the study. Depends on what tool you're using to measure it. Depending on what your pre-existing health problem in your population is. But the incidence goes from around 16% to over 40% for PTSD at long-term outcomes. And if you look at the meta-analysis, well, that confirms that there is a variable outcome. It goes from 4% to around 62% in outcomes, PTSD outcomes in survivors. But if you look at the average around, they probably stay around the 20% mark. So approximately 20% or 1/5 of our patients do have PTSD, and when you measure them at long-term symptoms later on. But about anxiety, a similar result from meta-analysis. So around a third of our patients, over 30% of our patients have severe anxiety a year or 2 years after discharge from intensive care. Same with depression. Around 30% of them have significant depression at long-term measurements. So that's interesting. Well, what could be the risk factors for that? Because that's probably very important for us to understand. Why is all this happening? Because that's not something we expect. We think that we've done a great job, people have survived, they've gone home, but clearly they're not doing all that well. So again, if you look at the ARDS cognitive outcome study, the cognitive outcome study followed up these patients for cognitive outcomes, neuropsychiatric outcomes after ARDS, and found that a significant number had anxiety, depression, and PTSD. But there was a signal, small numbers. There's only 100 patients followed up. Okay, so I wouldn't change your management on that. That's just a disclaimer. But the conservative fluid arm of the FACT trial actually showed that there was more cognitive impairment, and the liberal arm probably showed a signal towards improvement. Now, that doesn't mean that we start flooding our patients with fluid, please. That just means that we've got more work to do on this. Okay, so let's not change our management just based on a 100-patient study. What else could be driving this? I suspect the answer is in physical disability. There is probably a significant interaction between that physical disability that our patients go out of intensive care and the psychological sequelae to that. Even Carol's paper, the moderate to severe disability arm that she's spoken about in the survivors of critical illness had significant anxiety and depression. So that was the more disabled you are after discharge from intensive care, likely the more problems you have. So what are some of the risk factors across all these papers? Some of the risk factors that come out really are benzodiazepine use for PTSD. Well, hopefully we moved away from that. Unlike probably other countries where United States or something, I don't think we as a country use so much benzodiazepine for ongoing sedation. Memories of frightening ICU experiences, so those horrible delusional experiences that patients suffer from, that is a major thing that comes across all the categories. So that's a major risk factor. But pre-existing psychiatric symptoms, pre-existing psychopathology is a major risk factor again. So if your patient has pre-existing anxiety or depression, it is likely that that is going to get worse when they get discharged from hospital. So what does that mean? It means, we've got all electronic. We've got so many devices and monitors out there. We need to get out from behind those screens. We really need to spend some time talking to our patients. Just because they're sedated, just because they're intubated and ventilated, doesn't mean they can't hear you. And all that literature points to that, saying, give them actual memories of their time in ICU. Let's try and work on that. And don't forget the families, those caregivers, those families. There's a lot of literature out there which says that If you follow these caregivers up of critically ill patients, they actually have significant anxiety and depression as well. So 16% anxiety, depression in Jill Cameron's paper from the NEJM, and Kimberly Haynes' systematic review also showed a significant amount of anxiety, depression, around 20% anxiety, depression in these patients. So what about Australia? Let's bring it back here. I mean, we're different, of course. Our mortality is much better. Surely our outcomes has to be much better. Well, you know, if you look at, again, Kimberly's paper from Melbourne about the long-term recovery following critical illness, 5-year follow-up, 4 to 5 year follow-up. Low number of patients, only 50 patients at the 4 to 5 year follow-up mark. But significant problems. So around 20%, 11 to 14% with depression, 20% with anxiety, and around 16% with PTSD. With Carol's paper on critical illness, she's already told you that. Around 8% PTSD and anxiety depression around the 15 to 20% mark, but combined anxiety depression around the 20-22% mark. Okay, so why is that? So why are we better off? I don't know, it must be something in the water, or how we de-stress ourselves, or we're just stoic, and it's going to be all right. That's the kind of attitude the Aussies have. Probably. We don't know that, though. And it is possible that we're doing something right, whether it's the early mobility, it's the minimizing the sedation, we're probably doing something right. But, you know, the long-term psychiatric follow-up of our patients is not something that we've done very well. So we hope to try and change that. So we've got a study, which hopefully we should be sharing results in a few weeks' time, which decided to follow up patients for 12 months. But we decided to look at the non-intubated group as well, because everybody's excluded them, thinking, well, they don't really have problems. It's the intubated group that always has problems. And what we hope to establish is some prevalence of these long-term psychological outcomes at 1 year. And we're also going to be looking at health-related health status at 12 months as well. So how do we actually measure this? Because I've spoken a lot about that there is a problem. How do we actually measure it? How do you actually get out of here and measure it? Well, there are a number of tools. If you really want to diagnose PTSD, well, you need a 45 to 60-minute interview with a psychiatrist. That is not something we've got time to do. And our patients want to come back for that as well. So that takes time. If you want to diagnose depression and anxiety, well, again, you need a 1.5 to 2 hour clinician interview with a psychiatrist to diagnose that. So we can't do that. So what about some screening tools that we could use? Carol's mentioned a few of these tools before, but impact of event scale, 22 item scale that we're using in our study as well. So that just asks them to circle it. Can easily be done on the phone, can easily be done by the patients on their own if you post them out to them, or if you meet them on the ward, that could give you a nice baseline one. So that there are ways of measuring it, and it tells you about intrusion, avoidance, and hyperarousal symptoms of PTSD. There's the UK PTSS-14 scale, which was developed in the United Kingdom, as the name suggests. It's a 14 scale one. Misses a number of things, but it still could give you a rough idea about screening. The cutoffs for IESR varies on literature. Some people do a total score of 35. Some actually take a mean of each and sum them up. And the mean average greater than 1.6 is considered to be significant. With PTSS 14, that's total sum greater than 44 is supposed to be significant. So there are tools out there. And I'll talk about which one. I probably, if you had to use one, I'd use the IESR. For depression, again, a 20 scale one, the Center for Epidemiological Studies depression scale. Easy to screen patients for that. There's a scoring matrix that comes with it, or the Beck's depression inventory, which is slightly longer to print out, but 21 items as well. Or the hospital anxiety depression scale, which will do anxiety and depression, or the depression anxiety stress scale. Now, the hospital anxiety depression scale, you have to seek permission for. It costs around £100 to do it. The DAS, or the Depression Anxiety Scale, developed in University of New South Wales. It's a local tool. It's freely available. You just need to buy a manual for $40 or something, which will tell you exactly how to measure it and how to actually calculate it. But there's some useful tools out there. What about cognition? Well, there's the MOCA, the Montreal Cognitive Assessment Scale. If you want to measure cognitive function, again, you'll have to seek permission to use these tools. or the Euroqual score, the EQ5D5L, which is a very simple scale, which either you can do on the phone or the patients can do it on their own, which will tell you a number of things about their activity, how their health is today, and they can grade that on a visual analog scale as well. But Dale Needham's group has published this, and Carol's shown this as well. The core outcome measure sets go through what you should be measuring for mental health. If you had to, you'd use only those two ones, the HADS for anxiety, depression, the ISR for PTSD. What does it all matter, really, at the end of the day? Why? Why do we want to do it? Why do we want to measure outcome measures? Survival should be enough. Well, unfortunately, there is a lot of healthcare utilization in these patients. So if you have PTSD, your healthcare utilization is much higher compared to the normal population after you've been discharged from an intensive care. 33% readmissions if you had PTSD in this study. 40% readmissions in this study. So there is a significant amount of healthcare utilization. Not to forget that there is loss of employment. All these studies, and Carol's work as well, shows a significant amount of new unemployment in these patients after discharge from hospital. So we're talking about unemployment at the rate of 40 to 60% in these studies. So these people get out of hospital, you think we've done a great job, they go back, they're just too tired, they're too weak, or they have mental illness, they can't go back to work. So what does that mean, really? Yeah, we are probably winning the battle in intensive care. We've got more survivors, but we're probably just creating more survivors, really. And if you change your perspective and you look at it, there's victims in every battle. It's never just about mortality. It's got to be about more than that. And I think we've got to change our focus on looking at mortality outcomes and saying that we've done a great job, this patient survived. We've got to find out how they have actually survived, because there is a price of intensive care. And intensive care is not called expensive care without a reason. So thank you.